It's an exciting day today. Today is the last day of using Margel keys, and this is quite a landmark for the manufacturers of brass. But the truly exciting news is our presenter, Dr. David Margel, who received his MD degree in medicine from Hebrew University in 1998, followed by a general internship in general medicine in Tel Aviv in 1999, and then several years of residency in urology from Rabin Medical Center ending in 1908, and then a fellowship in bladder biomarkers from the Weizmann Institute ending in 2010. He is currently a clinical fellow in urology, a PhD candidate in clinical epidemiology, and a urologist at the Princess Margaret Hospital. Lots and lots of accomplishments, including multiple years of military service, rising to the rank of a captain in the Israel Navy submarine corps. Who knew that Israel had submarines? I don't know. Multiple prizes for research excellence. He's the first author on over a dozen Medline articles, and he is a protege to David Urbach. Now, this isn't your average run-of-the-mill PhD defense. Au contraire, we are allowed to interrupt the candidate. The individual will not speak in an uninterrupted manner for 20 minutes, and anybody in the audience, regardless of academic rank, is allowed to ask a question. David is willing to take it all, including comments already prior to the introduction. Thanks very much for being here, David.
Thank you for the introduction. I'm very happy to present work towards my thesis. As Dr. Redemar said before, my formal transfer was yesterday, so I am now presenting some of my results, my early results, in addition to my proposal, and I am willing and wanting to hear your comments in the middle of my talk. So my thesis topics are three. I'll first discuss metformin use and prostate cancer incidence, and on this study I'll take a nested case control approach. I'll then discuss metformin use and prostate cancer mortality, and in that study I'll use a cohort approach. And for my final project, I'll look at a more methods question as to whether pathology is necessary to predict overall mortality among prostate cancer patients.
Sounds great, David. Karen, is there a switch that used to be thrown, or some other signal for the microphone?
No, I've got it. We're on.
Okay, great.
We're on,
okay,
yep.
Good. Back to our review.
Okay. So prostate cancer is an ideal cancer for prevention. And why is that? First of all, it's very, very common. 18% of Canadian men are expected to be diagnosed with prostate cancer during their life. Second, the initiating event, the actual transformation of a benign cell to a malignant cell, occurs very early on in life, around the 4th decade of life. However, there's a very...
True.
What?
Sorry, no.
It's okay, they don't die.
I'm close to that. So.
See? You don't die straight away.
However, there's a very long latent period, and progression to clinically detectable disease only occurs around the 6th or 7th decade of life, and the median age of prostate cancer diagnosis in Canada is 69. Despite that, and despite a lot of money and a lot of effort from very smart people, there's no available preventive strategy. Metformin. Metformin is a drug that is commonly described to treat type 2 diabetes. Recent studies, both in the lab and outside of it, in vivo, have shown that metformin can prevent cancer. But how does it work? So there are two basic mechanisms of action. The first is it can promote programmed cell death, or apoptosis. And the second, it can reduce proliferation. And you can view metformin as a drug that takes energy out of cells that are rapidly dividing and really need that energy. And therefore it helps prevent cancer. However, whenever you want to look at prostate cancer association with metformin, you have another factor to consider, which is diabetes. The drug is people who are treated with metformin are diabetics. And diabetes itself is associated with prostate cancer. In most cancers, diabetes is a risk factor. That is, patients with diabetes are at increased risk of colon cancer, breast cancer, etc. Prostate cancer, the inverse relationship is probably true. And why is that? Prostate cancer is an androgen-driven cancer. It feeds on testosterone, and it needs testosterone to develop. However, diabetics have less testosterone because of metabolic syndrome and chronic disease, and therefore they're perceived to have less, a decreased risk of prostate cancer. And that's always going to be a problem when assessing metformin with prostate cancer. There's 3 general, large epidemiologic studies out there assessing prostate cancer incidence and metformin. All take a nested case control approach. The first 2 studies by Wright et al. And Mortola have an inherent problem because they use the general population as their nesting cohort. And it's very hard to tease out the effect of diabetes versus the effect of the drug. The third study by Azuali is a well-designed study from the McGill group. It again uses a nested case control approach, and it took the UK General Practice Research Database. However, it included only 740 prostate cancer cases, and it ignored a fundamental or a very important prognostic factor in prostate cancer, which is grade. It did not have any information about prostate cancer grade. And for us to conceive of any drug that will be able clinically to prevent prostate cancer, it has to have the ability to prevent high-grade prostate cancer, because that's the lethal prostate cancer. Low-grade prostate cancer is probably a disease a lot of men have, at least, when they age. And if you take the 5-ARI example, 5-ARIs are a class of drugs that prevent the transformation from testosterone to dehydrotestosterone, which is a more potent androgen. And they have been shown to be effective in prostate cancer prevention. There's 2 large studies, large randomized control studies, well-designed, that demonstrate a 24% reduction in prostate cancer incidence if you use 5-ARIs. However, they're not clinically used. And why is that? They do not prevent high-grade prostate cancer. They only work on low-grade prostate cancer. And there's even some theory that they may provoke high-grade cancer, but probably that's not the issue. With that in mind, our research question number 1 is, among men with incident diabetes older than 66, does treatment with metformin reduce the risk of prostate cancer incidence? And how are we going to approach this? First of all, we'll identify our nesting cohort. Our nesting cohort will be identified using the ODD, the Ontario Diabetes Database. And we'll take men with incident diabetes who are older than 66. And then we'll look at the Ontario Cancer Registry to identify our cases. And we'll use the ICD-9 and ICD-10 codes for prostate cancer. And we'll not only get the information on who's a case, but also ask for pathology, and therefore get the grade of all these cancers at diagnosis. And as I said, the grade is the major drive of prostate cancer and mortality or lethalness. Finally, we'll look at the ODB to get our drug exposures. We'll also use the Chi-Hi-DAD and stats to control for the various confounders. We'll have, our study design will include 4 parallel nested case controls. The nesting cohort for all these studies will be incident diabetics older than 66. Our cases will be different for each study. Study number 1 will include all cases, and the index date will be prostate cancer diagnosis. Study number 2 will only look at high-grade prostate cancer. And we'll use that as the index date. In study number 3, the cases would be low-grade prostate cancer. And the definition of high-grade prostate cancer is will be by Gleason score. The Gleason score is how we score prostate cancer's grade. And high grade is considered any grade with a sum of 8 or more. Low grade is considered any grade with a sum of 6 or less. And the fourth is intentional diagnosis. This is an interesting thing. When I started going over the pathology, I found out that about 20% of my cohort are diagnosed with a TUR, with a transurethral resection. Now today the common pathway, the common clinical pathway to be diagnosed with prostate cancer is a patient for some reason takes a PSA, he comes to his doctor, and this doctor thinks this PSA is elevated. And he refers him to a biopsy, and he's subsequently diagnosed with prostate cancer. A patient who's diagnosed with TUR is a patient who complained of symptoms of lower urinary tract symptoms. The doctor who operated on him thought he had benign enlargement, not a malignant cancer there. And inadvertently, on pathology, prostate cancer was diagnosed. Now, these two groups of patients may be very different, and therefore we're also going to look at intentional diagnosis. Our study period will be from 1997 to 2008, and we'll have a look-back period of 1 year to ascertain that there are... Yeah?
David, can you explain why you have selected incident diabetics rather than prevalent diabetics? And what is the impact going to be on your sample sizes, particularly when you start to stratify your disease categories?
That's a great question. I think first of all, for me to have all exposure to metformin, I have to have incident diabetics. If I use only prevalent, I'll be missing information about the exposure, which is metformin. In terms of power...
The prior exposure.
Yeah, the prior exposure. That's what I'm interested in.
Prior to the age of 66.
Yep.
When they may not have been in the...
Yep.
Would it be? Okay.
Yep. That's the main reason. For me to capture all exposure, I have to use incident diabetics. That'll give me the opportunity to look at all. Otherwise, I'll be missing a lot of years of exposure that may be more important than 66 and above. In terms of power, I'll show you later on. I'm well powered. Even I have more high grades than Abu Saleh had all comers. So I'm sorry. It's kind of a hard. I'm trying to.
It's deliberate.
Sorry to be looking behind yourself. I'm just wondering what you indicated that low-grade cancers many men live with and aren't even aware of. And so the detection of low-grade cancer may be more reflective of screening behaviors by the patient and physician than really of their pathology. And those behaviors may track with the aggressive management of diabetes and the evidence-based use of metformin. So you're going to have some biases in there. Given that your interest is really in high grade, why don't you construct your cohort of just people with prostate cancer and look for high grade versus low grade?
So you want to see if then the research question is different. The research question would be, does metformin affect the grade of presentation of prostate cancer? I want to look at that. I think I will have a backwards way of looking at that with this design, but I also want to have a statement to whether this is a preliminary study. We hope to form an interventional study at the end. And we won't be able to select those with high-grade prostate cancers and give them metformin or low-grade. So we want to know whether metformin has any potential in the future to act as something of a preventive drug. And that's why I think it's important not only to answer the high-grade question, but to answer the whole prostate cancer question. And in addition, low-grade cancer, Canada is very good in doing active surveillance. So only watching these patients and not treating them. Most of the world, a patient is diagnosed with prostate cancer, he gets treated. And I come
Most
from
of
a
them at
country.
Sunnybrook get treated.
What?
Most of them at Sunnybrook get treated.
Don't tell that to Dr. Klotz. But
It's 40% of the radiotherapy capacity at Sunnybrook is prostate cancer.
it's a lot. It's a vast amount of people, and so I think it is important to also tease out the low grade.
But the reality is all 4 of those groups of cases,
Mm-hmm.
it's possible that large majorities in each of those categories is in fact screen detected and associated with screening and other types of health service utilization.
Unfortunately, I don't have a very good way to. PSA is not OHIP billable, so you don't have to.
Well, it is now. There's 2 years of data.
Yeah, but unfortunately, not enough for me to. So I will try to get to the screening or control for screening. Since most screening is done at the primary caregiver, I'll control for primary care visits prior to the index date, but it's a very rough measure, but that's the best I can do for now.
Is there any evidence that different screening maneuvers are tracked together, so either the patient or the physician who's more interested in screening, they would also have gotten a colonoscopy in the last 5 years?
And that's another way I thought of doing that, maybe looking at those who get screening with colonoscopy. However, it's not. There's no evidence. It just makes sense. But I don't know of any. We also thought, since these are diabetics, to look at eye doctor appointments and stuff like that. Are they really? But these are all things that they're non-validated measures that I can use. So the rationale for the study design. Metformin is a classic time variable variant. People can go on and off metformin during the whole duration of the study. So the more natural way of doing it would be a cohort design, where you can account for time variable variants. However, I'm trying to stand here.
That's fine.
However, the McGill group again have shown that a nested case control design using conditional logistic regression gives similar estimates as COX with time-varying covariates if 2 conditions occur. If the follow-up is long enough and there's a large enough cohort. And we think our study, these 2 conditions apply to. It does it with computational simplicity. It's much easier to do, and it takes a minute rather than a day. And it's much simpler to interpret. It's much easier to interpret. And later on, when I talk about my survival analysis, and you'll see how I calculate the survival analysis, it's going to be very, very hard to implement what I'm trying to do there with a large cohort of about 1 million incident diabetics over the 66.
David, forgive me, but why conditional regression, and what's it conditioned on?
It's so we're matching cases to controls, and it's the stratas we're using to do the conditional, as opposed to the regular.
So they're matched on, sorry.
They're matched on, we'll soon get to it. They're matched on age and duration of diabetes.
Okay.
The cases and controls. But
But I guess you maybe got to come to it, but I wonder why it's matched.
why? So I'll tell you exactly. I'm going to talk about
it. It's the
it.
order of the presentation.
Okay, so I thought rationale, but yeah. But you're right. I need to give more information before I present why I'm doing and how I'm doing it. And in addition, another factor is that other studies have used nested case control studies, and we'll be able to measure our estimates compared to what they found as well. And now we get to how we talked about the cases, but we didn't talk about how we're matching, how we're selecting our controls. And we're matching on 2 things. We're matching on age, since age is the major driver of prostate cancer incidence. So the older you are, the more likely you are to be diagnosed with prostate cancer. And that has been shown in many, many studies. So it's a major confounder, and I don't think this study will be able to demonstrate anything if we don't match on that. It's a very, very strong confounder. And the second thing we'll match on is diabetes duration. And we're matching on that for 2 reasons. First of all, I said diabetes is a confounder, and we want to control for it. But the more important reason is for a nested case control design, you have to have the controls to have the same risk of exposure as the cases. So if they are both matched on the time frame from diagnosis of diabetes to prostate cancer incidence, they'll have the same risk of metformin exposure in time. And we are very interested in cumulative exposure to metformin, and therefore not matching on that will be problematic if we want to look at cumulative exposure to metformin, which I'll talk about in a minute.
Sorry, David. The Diabetes Association and the Endocrine Society, all the august bodies for diabetes, recommend metformin as initial treatment for new diagnosis of diabetes. Are you going to get enough diabetics who have not had metformin in your study?
Unfortunately, yes, I will. Since we all know guidelines are nice, not everybody follows them, and we live in a world where people do what they tend to do, regardless of guidelines.
Okay.
And I'll show you what I have, so you'll see I do have.
This is another thing about matching on diabetes duration. Diabetics at their assigned date of diagnosis represent a huge spectrum of pathophysiology, and much more so than persons who are matched on the date of their first MI, which was not fatal. There's diversity there too, but I think that diabetics on their ascribed date of diagnosis are incredibly heterogeneous. So are you really matching on, are you really matching? And the other thing too is that with your cases, can you really be sure that the cases have all been tested, and that considering the ones who aren't diabetic, that they actually truly aren't diabetic?
So my nesting cohorts are diabetics. I'm only including in my study both cases and controls are diabetics and incident diabetics. So they have to have incident diabetes diagnosed from the age of 66 and above. So that if they're elderly cohort, age 66 and above, I'm matching them on age and diabetes duration. I don't have a very good measure of diabetes severity. If I could match them on hemoglobin A1C, it would be nice. I don't have that information. But I would not match on that. I'd probably control for that. But I think the matching should be as minimal as I can to get some meaningful result. Because if I match on something, I lose the ability to measure its effect.
But you're going to be matching some people on the basis of either a case or control who on their date of diagnosis of diabetes already has end organ damage, and somebody else who just has a minimally elevated fasting glucose on a couple of occasions.
That's true. I did look at the, so there's, in the comorbidity index, there's a diabetes complication tag, and the patients tagged in my cohort are about 150 altogether.
Yeah, but those are only hospitalized patients.
ACG, I'm using ACGs. So the exposure I'm going to look in 3 ways. I'm going to look at ever versus never metformin. I'm going to look at metformin versus all other anti-diabetic drugs versus diet control only to try to tease out those who are diet controlled, have less diabetes, and try to look at that as well. But my major exposure is cumulative use. And why is that? I don't believe, and I guess my committee as well, does not believe metformin will prevent the initiating event, the actual transformation of a benign to a malignant cell. But it may prevent progression to clinically detectable disease. And much as cigarettes work, the more you smoke, the higher risk you are at for lung cancer or whatever. We think that the more you use metformin, we hope at least, that it's more protective the more you use it. And therefore, we will look at cumulative use, and we'll look at it at time and drugs. So confounders. Confounders are factors that are associated with our exposure, which is metformin, are determinants of the outcome, which is prostate cancer, and not in the causal pathway. The first two are obvious: age and diabetes duration. We've discussed them a lot, and we'll match on them. Comorbidities, we'll use the ACG score because of what you said, because most of these patients have not been hospitalized. And I also looked at the Charleston versus the ACG comorbidity score. Charleston's present for about a fifth of my population. ACG is present for everybody. We'll consider socioeconomic status or in rural status, other oral hypoglycemics. Insulin use is not that common, and you'll soon see very not common in my population, but if it were, it might have been a complicating factor because prostate cancer cells have insulin receptors on them. So that might be a very, very serious, even maybe an effect modifier. We'll also consider other putative drug exposures, preventions like statins and COX-2, and as I said, we'll also look for primary care visits in our analysis. We'll report the odds ratio of the incidence of prostate cancer associated with metformin use, and we'll use conditional logistic regression to account for all the confounders.
Sorry, David. Going back to the question of people who are screen detected, I wonder whether it would be possible to identify people who've attended family practitioners who make high use of screening tests. So in other words, high screening GPs, and therefore they are more likely to have been screen detected.
That might be possible.
Yeah.
I'm wondering if we want to separate those because although PSA screening is debatable, men have voted with their legs. They're screening themselves. No matter what we'll say about it, they'll get screened. And I don't think the FDA or the U.S. task force or whatever will change the way men. So men aren't going to get screened.
It may help you to identify those earlier stage, if you like, screening detected cases. That was the only reason I was thinking of it.
Yeah, that is true. I do have information from pathology, so I do know who has a low-grade, low-volume disease, and those are mainly the screen-detected patients.
But they're actually, the work has already been done. We know the screening behavior
of different physicians.
Of all primary care physicians in Ontario. Rick is
so that would be nice to add.
So that does exist.
Okay.
Now, are you implying that men can get a PSA without a doctor's order?
They can do that.
In Toronto?
Probably not.
No. Okay, so a doctor has to say yes, go and do it.
Yeah, but they can do it across the border without any.
Well, yeah.
But if they're high screeners, surely it would only matter if they're also higher prescribers of metformin. Have you any evidence that these two things are correlated?
Well, you could easily look at that. It would only take a day. And the other thing is you can
It would be very interesting.
You can actually look at what doctors have been ordering the PSAs in the last 2 years among men who don't already have a diagnosis or treatment of prostate cancer. Now, obviously, some of those will be doctors who didn't, but you could actually do sort of an analysis that probably is not biased by trying to find one answer or another about the doctors and whether the people who send large numbers of people for colorectal screening and people who get a periodic glucose and a periodic fasting cholesterol, are those same doctors sending for PSA as well?
It would be a very interesting study, looking at tendencies of screening among.
Sounds like another study, though.
Yeah, it will be.
We're interrupting you, David.
No, but it's an interesting one.
It's an interesting study.
Just another question. So one of the biggest contraindications to metformin use is renal insufficiency. So by nature, people on metformin will be healthier than people who aren't on metformin. Do you think the ECG system will be sufficient to account for the differences in levels of morbidity?
I don't have a very good answer for that. I hope it will. But again, when I looked at my cohort, there are very little patients with flags on that, on kidney problems or any complications of diabetes in my whole cohort.
Right, but there could be a lot of men with a creatinine
Yeah,
from 1 in 200, and they just don't have any code associated with
Yeah, but
that.
would
You
you
don't have the
prevent them
results.
from metformin, 1
Yeah,
to
a lot of
200?
people-
Yeah, a lot of,
Yeah. Well, and the cumulative dose would be less, so a GFR between 30 and 60, you can use a half dose.
yeah, but I'm not looking at dose at all. I'm
Yeah,
looking at day supply.
But the
So-
cumulative.
Oh, okay.
Because I can't do dose. I can't do dose. I want to do dose, but since sulfonylureas, there are about 4 or 5 different drugs. I can't compare the dose of all these. So I have 40 milligrams of this versus 10 milligrams of that.
But over time, they'll be on less days, presumably too, because they may have progression of renal insufficiency or other
But
reasons to come off.
do these guys have a lot of renal failure? I mean, most people with prostate cancer have got normal renal function.
Well, the elderly have reductions in EGFR just on their own.
But
They have
match
less-
for age. There's studies
Yeah,
match
you're
for
right.
age.
I mean, it may be that you're going to be okay. I mean, there are CKD algorithms too that you could potentially
Yeah.
adjust.
I mean, there's clearly
It's all about
selection
diabetes.
bias in the
Right.
diagnosis of prostate cancer, and if you couldn't look at diabetic, on average, the men who are diagnosed with prostate cancer are going to be healthier.
That's right.
Right?
That's true.
Now, within diabetes,
Actually, I'm seeing the opposite here.
That's true.
who have had diabetes, the question is there selection among them? Is it that are the more robust diabetics more likely to be diagnosed because of general?
So it's interesting that you say that they are less likely to be sicker, but I'll show you what I have now. They're actually the reverse. At least in my cohort, they're sicker than the controls.
Among the diabetics.
Among the diabetics. And I'll show you again. So the numbers are, here are the numbers. So even if you take the high-grade prostate cancer, which is the lowest number, I'm still way, I have more numbers than the largest well-designed study
So
so
these
far.
are diabetics with
These are all incident diabetics, incident prostate
incident.
cancer.
Okay.
And pathology I abstracted from 4001, that's 82% of my cohort. The rest did not have pathology available. So here's some results from just baseline characteristics. These are elderly patients. You see the mean age of diagnosis is 76. These are not regular prostate cancer patients. These are elderly patients. The mean follow-up from prostate cancer to from diabetes to prostate cancer is 3.6, and I matched on that. The socioeconomic status as well, balanced between the groups. The ADGs, however, it appears that the prostate cancer patients are sicker than the
Did you take
controls.
all the cancer-related
Yeah, of course.
ADGs out?
Yeah, I took the cancer-related ADGs out. What I'm doing now is Peter Austin validated something on survival, which I'm using for my survival analysis, a weighted ADG score. So I'll change this to a weighted ADG because it doesn't make sense to take pregnancy, eye exam, and give it a 1 score, and give severe psychiatric disease or the same 1 score. So he developed a weighted ADG score, and he validated it in survival analysis, and I'll apply this also here to see whether I'm getting similar results with a weighted ADG. When I applied it to my survival model, it was much more predictive than just the sum of ADGs. So that's a different study. Yeah.
Sorry, David, I know these data, but I just noticed here now that the number of GP visits just was, is that the mean one?
Yeah.
I want to
1.1.
double check that because that usually we see many, many more, even in.
Yeah, so I think I'm not really, okay, I'll double check this.
Oh, yeah.
Yeah. Yeah. Per year, so it's 2 years prior to index date. How many?
Oh, prior to index before.
It's not all together. It's 2 years prior to index date.
Before being diagnosed
Yeah.
with diabetes.
But then diagnosed with
really
Still
low.
seems low.
Okay.
Really.
So I'll double
Just
check
want to double
that.
check.
Yeah, sure.
Yeah, usually we see
Yeah.
like 6 to 7 per year.
Okay.
Healthy people.
And these are my other drugs exposures. So here are some numbers regarding the exposure, how many were exposed and what happened. So this is the univariate analysis, and unfortunately in the univariate analysis, I'm finding that metformin use is associated with an increased risk of prostate cancer. rather than a decreased risk of prostate cancer, which I hoped to find. Actually, this is similar to what the Margel group found, that it's associated with an increased risk. And that might be the biases introduced by all of everything we said. These patients are those who are getting better treatment or more diagnosed, and this is univariate analysis, and we'll see what happens on multivariate analysis, whether this stays true or not. And in addition, I think the most important things...
Sorry, you've got a dose effect.
Okay, I'm sorry.
My apologies, you've actually got a dose effect there, David.
Yeah. Yeah.
So that's for every year.
So yeah, what I did is...
5% increase in relative risk.
Yeah. This is univariate analysis for now. Yeah.
I just have one more comment about the controls, which there may be some contamination there because Sue Bondi and Nino and I had a publication about 12 years ago where we looked at the use of LHRH agonists in older men. And over a third did not have a record in the cancer registry. And so what I would do, I mean, this isn't going to change your results, but it may reclassify some people. It would probably be a good idea to make sure that the controls haven't had LHRH agonists or radical prostatectomy. Because we know that the accuracy of the cancer registry overall is plus or minus 3%, which some people think that's terrible, but it actually varies a lot between the cancers. And one of the suspicions that everyone had in the past was that there are men who get a PSA,
don't get a biopsy,
don't get a biopsy, or the biopsy is, for whatever reason, it doesn't diagnose cancer, but if the PSA is high enough, and whether or not...
I sometimes start treatment without a biopsy.
It was like a third of the men who had not had it between 65 and 66. So we just did what you did. We started looking at 66, and a third of the men who were receiving it had no diagnosis in the cancer registry.
So that would be easy enough for me to look at, because I do have anti-androgen exposure in LDV. I asked for that, and I can look for both. I can look for that. It shouldn't be a problem to look for. I will. Third. That would be interesting. It's very rare. I think in my 9 years of residency in urology, I started twice. Saw a lot more prostate cancer patients than I started hormonal therapy.
No, but you're in a very
academic
center. But you have a community urologist in Huntsville or Peterborough, and he's got a 79-year-old man, and the PSA is 120, and he's got pain in his back. The simplest thing to do, well, 50 years ago he would have had immediate castration and felt better. Now he would probably get an LHRH agonist and feel better within a week or so.
Okay. Yeah. Interesting. But I think the most important thing is I'm still waiting for my hybrid results and the multivariable analysis, of course. Now we're switching to a different mode, survival analysis. So is metformin use associated with prostate cancer mortality? Here the study will be a cohort design, and the index date will be the date of prostate cancer diagnosis, and we'll follow them up till death, prostate cancer or other, due to prostate cancer or other, or end of follow-up. We'll only include the 4,001 we have pathology available, because pathology is a main driver. And the outcomes will be to time to prostate cancer specific mortality and time to overall mortality. The exposure, as I said again, will be cumulative use of metformin. And we'll look at it as a time-varying covariate. And cumulative use here is evidential by how we think of metformin works. It may prevent, as we said, progression. And that's how we hope to see the biological effect. And the cumulative use of metformin has the potential to change for every day of follow-up in the study. And therefore, we'll have to design our database to include a row for each patient for every day he's on the study. So for example, if you take subject number 1, he's on our study for 4 days. He started metformin on day number 2, stopped it on day number 3 and started it again at day number 4, and his cumulative use would be 2. And with the 4,001 patients with about 4 years of follow-up, we're looking at a database that's about 7 or 8 million rows. The confounders, we listed them again. The only true difference is we'll add grade and volume of disease as we captured it in pathology, and we'll also add the treatment. And we'll also consider that as a time-varying covariate, whether they received radical prostatectomy, radiation, or hormonal therapy. Cohort entry is also important since these people, changes in both treatment of diabetes, as we heard earlier, and with prostate cancer treatment during our study period, changes have been made to both diabetes and prostate cancer. And we'll consider all other drug exposures the same way we consider metformin. So we'll use all other hypoglycemics, sulfonylureas, TZDs, insulin as time-varying covariates, and we'll measure the cumulative use for every day on follow-up, as well as the other putative COX-2s and statins. And we'll report the hazard ratio, of course, associated with mortality, associated with metformin use. Hazard ratio of mortality of prostate cancer, associated with metformin use. Major problem here is the validity of prostate cancer specific death code in OCR. There's no specific validation on prostate cancer. There is a specific one for breast cancer. And breast cancer and prostate cancer share a lot of similarities in terms of overall survival. These both survive for a long time. And we do hope this is valid, but we're also measuring overall survival, not only prostate cancer specific survival. So if you look, this is table 1 for my cohort. Unfortunately, I don't have a regular design. Most of my exposure is post-fact. So I can't really divide my cohort into exposures like you normally find in a survival analysis, because all my exposure is after they're diagnosed, after the index date. But the median age is the same, 76.1, of only the 4,001 included in this study. The follow-up time this is follow-up time before prostate cancer diagnosis. So these are all incident diabetics. I have all exposure for them also prior to their diagnosis. And that's also important because I want to account for the exposure of metformin prior to prostate cancer diagnosis. And that's 3.4 years, and the follow-up from prostate cancer diagnosis till censored or death is 4.2 years. The grade of presentation, you can see, primary treatment is as expected. These are elderly cohort. Usually you don't treat those with surgery. A larger percentage of them have radiation, but a large percent of them have only watchful waiting or ADTs.
So what were all the elements you looked at to define radiation?
I looked at OHIP billing codes, and now I had to employ, first of all, an algorithm to ascertain this patient wasn't only consulted, but was also getting treatment, hopefully, because I had his initial consult.
You used the planning codes?
Yeah, I used the planning codes, and then I looked to see if the patient was followed up.
Did you look for the brachytherapy codes?
Yeah, a very little amount had brachytherapy. In addition, I captured those with metastatic disease getting metastases. But then I forced a clinical judgment call to decide that those who were on radiotherapy couldn't die of prostate cancer within 1 year of diagnosis, because those are not the patients who are treated with localized disease. Nobody dies out of prostate cancer within a year of radiation therapy. And because at first, when I ran the model, I found that radiation therapy was associated with an increased risk of mortality, and like a 70% increased risk. So I think I captured just the got radiation because of metastases. And when I did that, it eliminated what radiation was actually protective, as I thought it would be.
Well, it reflects selection bias. You have to be just almost, in the same way that the surgery reflects selection bias, you select the better people to give radiation to.
Yeah, of course. Of course, and I hope it does affect outcomes.
Well, we don't have much evidence. Like, there's never been evidence for anything about the single digits, except for APT.
Okay.
David, you alluded to palliative radiotherapy, and things are different potentially in the last year or 6 months of life. One of the things that may be different is you aren't so concerned about managing the diabetes of somebody who is on their palliative journey. And so for, say if that's the last year, for a quarter of your observation period, the people who are going to die may be off metformin, not because metformin wasn't a problem for them, but because at this point they're already losing weight and feeling unwell, and managing their diabetes is no longer a priority. Would there be benefit in having a pre-death lockout period to...
But that would be a regression to the mean, to the null. That would cause a regression to the null. And I'm finding actual benefit in 0.5 soon see. So even if I am including then that the regression to the null, I'm less worried about it. I wouldn't want to make a false conclusion, but if I don't find something that's there, what can I do? So exposure to anti-diabetic drugs. So the numbers are, this is before prostate cancer. And as you see, that's what happens to these people before prostate cancer diagnosis. So not everybody's getting metformin. And this is exposure after prostate cancer diagnosis. So a little more are getting it, but not a lot more, even with almost a 9-year follow-up. Now, I looked at other drugs, and apparently what you're all saying is people who follow guidelines, and statin use is correlated with metformin use. As if you put your clinical judgment, it should happen. And since my main exposure is metformin, I had to exclude statin use from my model, and knowing that what I might see may be the effect of statins, but I don't have any way to tease it out. These are the multivariable and univariable adjusted hazard ratios for cumulative metformin versus the other drugs, the other anti-diabetic drugs. So you can see that cumulative use, so skeptics may say that cumulative use is of course associated with survival because patients who use more obviously survive longer. The answer to that is two factors. One is that may be true in univariate analysis, but if I'm treating all the drugs the same, I'm controlling for that on multivariable analysis. Because if that were true, sulfonylureas should show the same, TZDs should show the same, and insulin should show the same. Maybe insulin not, because it's a surrogate of bad disease. But at least sulfonylureas should show the same. That's the first argument I have, that at least in a multivariable analysis, cumulative use does not mean more survival because they're just longer follow-up. The second answer is that in a Cox proportional hazard model, you assume that the hazard ratio, the proportional hazard, is the same between 0 and 1 and 500 and 500. So if there's a benefit, it should be the same along the continuum of the study, not only because they're survived longer. And what I interpret, at least from these results, is that each 6 months of metformin use is associated with a 17% decrease in prostate cancer-specific mortality, and that's the adjusted model, and a 9% decrease in overall mortality.
Sorry, you're saying it's different from the other diabetes drugs?
Yeah.
Sorry, on what basis are you saying it's different?
Yeah. What do you mean?
Well, is it just on statistical significance, interpretation, confidence interval?
First of all, sulfonylurea, there's no scientific rationale to believe sulfonylureas help prevent cancer mortality. And we know that they're not associated with an increased overall survival in the general population, not associated with cancer. So metformin is associated. So the basic science suggests that metformin may work. And in addition, with what I hopefully add to the basic science with the epidemiology data, I think
But another interpretation, I'm sorry, is that another drug used for a very similar indication chronically and orally is associated with what I think you're saying is then a residually confounded, adjusted odds ratio of 0.86, that's sulfonylurea. That your metformin is 0.83, but it's statistically significant, but these upper confidence levels are very close. I would say this is probably evidence of confounding rather than causal association.
Yeah, and I think maybe one way of helping us understand it is maybe giving us a sense of what proportion we're on metformin versus sulfonylurea, because maybe your numbers are just much bigger on metformin.
So the numbers are here.
Yeah, see.
Yeah.
The other thing, David, is did you look for a correlation between metformin and sulfonylurea?
Yeah, I looked for a correlation between all these drugs.
And was
The only
metformin and sulfonylurea?
No. The only correlation that was significant was statins either before or after, and
Because
metformin
one of
either
the
before or
concerns,
after.
David, is with this is perhaps the cumulative sulfonylurea is tracking with the metformin, because very often they're used together as combo therapy. So I don't know how much power you would have to separate out like
Only those who
monotherapy.
use, but I can do an interaction term in my model.
Yeah, 'cause
It'll
the
just
two
take it a
are
long
often-
time to run, but
Yeah, because they're often given
Uh,
together, so if you truly believe that metformin is protective, you might be picking up a metformin effect in your sulfonylurea group. That's what I'm saying. Because many of those sulfonylurea patients are
Yeah,
also on metformin at the same time. Because you're, yeah, that's what I'm
But
wondering.
there could also be something,
Other
or
Sure.
some other confounding, the people who end up on, or the commonly used oral hypoglycemics, whatever leads
Yeah.
to that is itself confounding.
Yeah.
That's,
They're early, they have milder disease if they're on these
that might be
drugs.
true here because we have less events here, but here you see much. So
I think you're hanging on rather rigid interpretation of confidence intervals.
But the
Maybe
dose
a very
response
small
are-
difference in point estimates.
Yeah, that's true.
But
They're not convincing.
the other thing that goes along with that is even if you could have somehow, even if this was results from a randomized study, even if it was that, sure you've got a so-called protective hazard ratio. How much of the variation in mortality is actually associated with the variation in the use of these? It's probably very little, right? So even if this was ironclad, you've got a hazard of 0.83 or 0.91. What that still means is that prostate cancer mortality is being driven primarily by the prostate cancer, and so whatever your beneficial exposure is, it might make a little dent, but really it's the force of fatal prostate cancer that's driving the mortality. For it to be otherwise, you'd need a hazard ratio of like 0.2 or 0.3.
But that would be unreasonable for it.
Well, no. Actually, all of the series of breast cancer prevention trials had very low hazard ratios among the women who took either raloxifene or tamoxifen.
That's a drug that specifically addresses breast cancer. It's not.
Well,
this is
but
does
that-
not.
I- but
Like
that may be-
anti-androgens, I
but-
would
but
expect that.
That might be part of the message, though, is that unless somebody can come up with something that will attack a target either in the initiation or in the early promotion phase of carcinogenesis, that it may be that that's what the doctor ordered.
The thing is, I don't want to. Usually, the drugs that treat cancer are also bad for the other parts of the body, and the human body is composed not only of the cancer. He has a body, surrounding the cancer. So I don't think if there's not going to be, I don't think I'll ever find a drug that's not designed to treat cancer that'll have a hazard ratio of 0.2. That would be, I might, but that would be nice.
Just at a practical level, Dawn's had to leave, so
Okay.
I'm going to step in as chair. What I think you have to take away from this is a certain level of skepticism
Of course.
about the effect you're seeing here, or what the interpretation of the effect is. Do you want to, great presentation though, do you want to start a wrap?
Yeah,
Looking
sure.
at time.
So, okay. I'll just talk about for about a minute or two about the research question number 2. So research question number 3 is a methodology question more. Is pathology needed to predict overall survival in prostate cancer? And why is this important? Admin data are powerful tools to predict survival in the general population. However, when cancer is factored in, usually it drives mortality. And therefore, consideration into the cancer part of things is very important. Prostate cancer is not that, we're not so sure about, because most people die with prostate cancer than from prostate cancer, and it can be perceived as a chronic disease. And therefore, we want to see whether the overall accuracy of a model to predict overall mortality is better in patients with pathology versus without pathology. And pathology is expensive too. It's expensive, it's time consuming, and it's a pain, believe me. A month and a half of my life went on to extracting those pathology, and I wish I don't need to do it again. So we'll compare 2 time to event models, one with admin data only, and nested within it would be admin data plus pathology. And we'll use the C statistic as well as other measures to see which model better predicts overall mortality. So the limitations of all of these we'll put together. First of all, our exposure will be only established over the age of 66. And as we said, we don't think metformin affects the initiation event, but rather the progression. And therefore, it's a feature and not a bug. The data does not include several factors that are important for prostate cancer. It doesn't include family history, BMI, race, or screening, as we all alluded for before. And lastly, and most importantly, how generalizable is our data to the general public? Will we be able to say with our results, we now have sufficient evidence to come up with an interventional study for the general non-diabetic population who are not 66 and above or younger. Despite this, a novel and effective way to prevent prostate cancer is desperately needed. Metformin holds promise as a safe, it can be prescribed to non-diabetics. There's a minimal side effect to this drug. And it's very inexpensive. It costs about 48 cents a day. And we hope that through this population-based data, we'll have enough evidence to support definitive phase 3 RCT and hopefully take the sugar out of prostate cancer.
Small surprise, we decided to make this too formal for this day.
Thank you.
We kept you relaxed out of a suit, silver-necked shirt, by not letting you know in advance. A great presentation, really, because from the amount of interaction and questioning there's been, and David's been kind enough to allow people to interject and ask the questions along the way. And I think that's been very useful because it really explored a lot of methodological issues as well as the underlying study questions. So it's been a really, really good, enjoyable presentation, David. So thank you for that, and absolutely best of luck with the rest of the work. Any final questions that people have about, or comments that people have on this? Sorry, I'm just going to point to them.
Yeah, so just a comment that when you look at your survival model for the all-cause mortality and the prostate-related mortality, so you had a lot of, like, I think about 1,400 cases where it was like all-cause mortality. So you might try to look at the competing risk, like the adjustment approach. You have those them.
Yeah, I'll do it with a competing risk model as well.
Yeah, so you have those side by side, but you may want to adjust the.
I am planning to do a 0-1 event and look at competing risk as well.
Good point. Thank you. Other questions, points, comments? As we close, we're on the hour. We're slightly past it. I think we're going to let you go, David.
Thank you very much.